Welcome to Kno2fy, a podcast recorded at the intersection of today's problems and tomorrow's care. Hosted by Kno2's Therasa Bell and Whitney Cole, Kno2fy brings together the voices shaping healthcare, from industry leaders and policymakers to the voices that don't always get the mic. We'll get into what's working, what's broken, and the hard conversations healthcare loves to avoid. This is Kno2fy. Let's talk about it.
Welcome back to Kno2fy, everyone. I'm Whitney Cole. Today, we are talking about how the industry built data exchange systems that don't actually serve patients. And I've got two awesome people here who are fixing that. As always, I'm joined by my co-host, Therasa Bell. She's the president and founder of Kno2. She's built the infrastructure to connect hard-to-reach providers. We'll talk more about that as we go. And then I've got Jason Kulatunga here today. He's the founder of Fasten Health. They're enabling patients to access their own records through individual access services, and I'm going to let him tell us more about that. But Therasa, welcome.
Thanks. I thought you were going to say Jason Kawabunga. Isn't that? we were having this funny thing right before for the listeners discussion on how to pronounce his name, and none of us are close. He can't even say it. He said so. Here we sit. I am super excited to sit here with Jason. I have from day one of meeting Jason, I have had tremendous respect for how he approaches business, how he approaches the problem statement. We were very privileged to bring him on. In fact, I think I'll just take 2 seconds, Whitney. I think my very first question to him and request was, hey, we'll do whatever we need to do to get you on our network economically or whatever. We are going to look to you to be our expert, right? This is when IAS was just getting started. Everybody's cutting their teeth. And I said, if we can come to that kind of handshake agreement, and he's absolutely lived up to his side, we've worked to live up to our side. But it's been a great partnership, and he is amazing to work with. So huge industry advocate. We couldn't be partnered with a better person on the IAS side.
Thanks for being here, Jason. Do you want to
Tell
us more about yourself?
Yeah, I'd love to. Jason, I'm the founder of Fasten Health. So Fasten's an interoperability platform that makes it easy for patients to share their medical records with organizations that they trust. We integrate with about 70,000 healthcare institutions via direct EHR integrations. And with Theresa's help, we were able to become one of the first organizations to pull medical records from the TEFCA network. So it's a pleasure to be here.
Yeah, we're excited to have you. I've been looking forward to this conversation. I was wondering if you could kick us off by giving us a working definition of what individual access services are. Why does it matter? What is it? Just get us all on the same page.
So from the perspective of a patient-facing application, an application that's being used by individuals, it's very difficult for them just generally to access medical records. Traditionally, it's been dependent on patients essentially uploading copies of their own medical records by taking photos or uploading PDFs they exported from their patient portals. Individual access services, at least on the TEFCA network, is incredibly valuable because it actually lets patients consent and pull their medical records electronically. It handles all the authorization, the consent, the actual data collection in electronic format. So you don't have to worry about putting all this additional burden on the patient to actually go find all their data, to log into all their patient portals. It's a much more streamlined experience, and it can really unlock this data for all of these types of applications that patients traditionally wanted to share data with, but there was so many barriers that it wasn't really feasible for them to do at any sort of scale.
Therasa, do you have anything to add? Anything from your perspective on why it's so important that patients can access their own data?
Well, I mean, yeah, there's a lot. That topic we could spend, I think, the entire segment, the entire time we have allotted here just on that one question. There's many benefits to it on why patients need access to it. I want to go back to, Jason said a number of things that I think are really important to, I'm going to be Fasten for a second. So I'm an employee of Fasten. You can fire me at any time, Jason. One of the things Jason said to me early on that really caught my attention, and I hope I'm not getting this wrong, Jason, so correct me real time if we need to, is he's like the Stripe for healthcare, right? So Stripe for individual access, Stripe for, so the infrastructure that Fasten has built is not only, I had made the mistake early on to say, okay, Fasten built this app, right, that they can do this query and go get access to it. And in fact, they're enabling IAS and they're enabling patient access across the continuum for those that want to do that. So whatever the use case is, and again, make sure I'm right here, Jason, they can come back to Jason and say, hey, I have this use case for individual access or patient access to their records. Can I use the infrastructure and the technology you've built to get access to it? So he takes huge portion of that equation out for these people that have use cases, and then they can sit on top of the Fasten framework and get access to it. Is that accurate, Jason?
Yeah, and I'd also add that like there has been ways to get access to medical records in the past, right? But they were, like I said, they were all very difficult. They weren't really scalable. And what you get with the TEFCA network, what you get with the Cures Act and the Patient Access APIs is this way to get access to medical records that are electronic, that are scalable, that allow patients to use or to share their medical records with these types of businesses that traditionally had significant amount of difficulty accessing data. So you can imagine types of experiences like a care coordination application or a personal health record app or a legal record retrieval service that's helping a patient fight back against a claim denial or even clinical trials, right? These types of businesses that needed access to records but weren't treating the patient. Traditionally, their mechanisms for accessing data was to have the patient, sign a record release form or a HIPAA waiver, depending on what they're doing, and waiting 3 weeks or 3 months for those institutions to fax back a response. So it was very time consuming, it was very manual, it was very difficult to do. And the TEFCA network, patient access APIs, they open the door for electronic, almost instant, real-time access to data. And so, when you're talking about, what Fasten's attempt to become something like Plaid for medical data, we want to be that
Yeah,
foundational building block. Yeah, we want to be that that
not so. You're right. Sorry.
yeah. No, but it's great. We want to be that building block that these organizations build on top of, such that they don't have to worry about the difficulty, the complexity around accessing data. Instead, they can just integrate the one API, and we can kind of facilitate record retrieval from all these different data sources.
Yeah, I think so. Whitney, to get back to your question, I wanted to make sure that people understand just how powerful the Fasten application is, how powerful the infrastructure is that Jason has built. Back to why patients should have access to their data. I mean, it's weird that we're even having this conversation. Sorry to say that. Who shouldn't have access to their own clinical data? I think I have a little bit of probably a controversial opinion, which I'll give just a little bit of it. And I know we have some questions queued up for later, so I'll get back to it. But I was sitting at the initial CMS Align Network event, now roughly, I guess, a year and a half ago. And I was on stage, one of the panelists, and they asked about individual access. And of course, we are all over that, right? We think it's hugely important. However, I do not believe that the best use of patient access and individual access should be to solve fundamental institutional problems of care coordination. We should be solving provider to provider communication. That needs to happen. And that burden does not need to be on the 72-year-old Medicare chronic patient to make sure that her records are transiting, are going between providers, and that is an inappropriate use. And we're mixing policy, we're mixing concerns, and I'm seeing it happen at the national level. That is, sure, it can absolutely be used for that. It's like we couldn't make it work between providers. And so we said, you know what, we're going to put the burden back on the patient because we think this is the only way that we can make it work. Not good. That is not a good use. IAS and patient access to their records should be used. Sounds like I told you I would talk about more about it later, but you asked a question. So here I go. Should be used for a patient to absolutely be in the center of their care. Making informed decisions, understand their conditions, being able to use AI, being able to use everything that puts them in control of their care, but not to fix the deficiencies in our healthcare system. We need to solve that independently. And then collectively, those two problems being solved, man, that's a whole new world for everybody. So all about it. I'm super passionate about the topic. And I think patients should have access, for obvious reasons, have access to their complete medical record. There's not much to say there. And if we're having topics to discuss the value of that, then, I just need to bag it up and go home, because I can't participate in those conversations. That's obvious on its face.
So connecting the dots a little bit, where does Kno2 come in? How do we fit together with Fasten?
Yeah, it's interesting because we're going through this exercise right now, just so people can kind of know what's happening within the Kno2 world. We're going through some refinement of who we are as an organization and our messaging and so forth. And we are a provider, a network for providers. So when I say that, that sounds exclusionary, right? So it sounds exclusionary to the patient, to payers, and it's actually the exact opposite. Where we have focused to the provider community that were left behind. And people have heard me say this on umpteen podcasts and probably ad nauseum. They're done with the story. But it's important because Jason brought out, and congratulations, by the way, on 70,000 organizations. That's amazing. But we have 700 to 900,000 organizations. That's what's estimated to be out there for provider organizations across the continuum for a patient to have access to. So you're awesome work, Jason. That's a huge number. And it happens to be probably to the health systems and physician offices, right? Primarily. Not saying that's all of it, but primarily. And we're solving the rest of that equation, right? So you look at 700 to 900,000, he solved 10% of that challenge. And we've got this remaining huge aggregate of providers that sit with technology, never been certified. They don't have patient access APIs. And so the only way it gets solved is through infrastructure like Kno2 and individual access. That's our focus, to solve that complete problem. Because if you look at again, I'll use the example of the 72-year-old chronic Medicare patient. They probably get access today, if they're going to go sign up for an app that's fast enabled, probably 30 to 40% of their record at best. They can get access to it at best. And then that remaining part of that record, so whether it's sitting in a skilled nursing, I had some home health, which absolutely almost all of them do. I'm in dental, I'm in vision, I'm in all of these things. And I have these very, very important parts of my record completely black hole, right? Can't get access to it today. We're working aggressively to solve that problem. And you saw us at HIMSS, Jason. We have all these providers and their technology to bring online. And so when we say we are a provider-centric network, it's to the benefit of patients, because we're focused to getting these providers online, enabling the patients that they care for and the access to the records that the patients deserve, but also enabling workflows that facilitate communication between patients and providers, right? But we focus to what can we do to create the best provider ecosystem so people like Jason can come online and get access to it. Payers can come online and get access to an ecosystem of providers that they've never had access to before. That is our entire focus. The two actually are very synergistic in terms of what we're focused to and getting done.
So we've been talking about interoperability for decades, and based on what you said, like, we're not entirely there yet, since there are still providers who are not connected. And that's what Kno2 is bringing to the equation, is getting those providers online. Jason, why do you think interoperability hasn't worked up until this point? Like, what's different now that gives you hope that we can get everything connected?
So I think there's a couple of things, right? So the Cures Act really opened up the floodgates to consented access to medical data. Prior to that, if you wanted to build some sort of patient-facing experience, you would need to partner with each healthcare institution individually. You can sign BAAs with them. You need to convince them first that it was a worthwhile endeavor for them to let this untrusted application connect to their system. Once you did that, you would have to replicate that experience with the hundreds of thousands of healthcare institutions across the U.S. if you wanted to actually build some comprehensive application that was able to pull records for any American. And so it was a scale problem, right? It was something that was very, very difficult for any individual small application to do. And some very large organizations did attempt to do it, right? Microsoft Health, Google Health. But they were defunct attempts. They didn't really go anywhere. And that's primarily, in my view, because of the friction involved with accessing medical records of this kind of scale. I think that has been solved in a way by the Cures Act. The Cures Act essentially said the healthcare organizations are responsible for making their data available and accessible for patients to access. Now, these healthcare institutions themselves don't really write software just generally. And so that mandate kind of rolled on to the EHR vendors that are actually powering the software that's running at these various healthcare organizations. And so the EHR vendors are the ones that are required as part of their certification to make the data available via their API. And so an organization like Fasten can connect, right? We can integrate with each of these health systems and their EHRs individually, and that's what we've done with 70,000. But even there's a scale problem. There's 700,000, or the math that we did, Theresa, was actually 450,000. I didn't realize it was all the way up to 700, but it's significant. It's a lot of different APIs and integrations that you have to do. It's hundreds of different EHR and software vendors that you have to integrate with. It's maintenance. And so the promise of something like TEFCA, of the value of Kno2 to Fasten, is that we can integrate with one network. That network then essentially becomes a door from which we can query and get medical records for any institution, any health system, any EHR that's connected, without having to manage and maintain all of these disparate, different software vendors and connections that we've created on the patient access API side under G10. So, sorry, under the Cures Act. So it's, it's something that we view as one of many data sources that we know we're going to have to stitch data together from these various sources to kind of create this comprehensive longitudinal history for patients. But it's one door that has a significant amount of value for us, right? It'll basically really simplify the amount of effort and work that we have to do to help patients access their own medical records.
So you mentioned the 21st Century Cures Act, and that was when it became clear that patients have a right to their health records. It's still hard though, right? Like what's standing in the way of making individual access possible?
So I'd say there's still a couple of pretty big areas of friction with the Cures Act. The first is, for a patient, you put a lot of responsibility on them. The patient has to remember all their healthcare institutions by name. They have to log into their patient portal before they can consent and agree to share their records with an app. And this only consistently applies to medical data, to clinical data, clinical records. When you talk about the health system, it's not just clinical data that's important to the patient, it's claims information. And so there is another, let's say, associated piece of legislation that is supposed to force payers to also open up their APIs to make that data available. But unfortunately, it only applies to Medicare, Medicaid, and federally funded exchange plans in a consistent manner. And so what that essentially means is, for patients who want to get that full comprehensive view of their medical history, not just the clinical data, but also the claims information inside of one application, that's just not possible via the regulatory, let's say, environment that currently exists. Going back to the value of TEFCA, the value of Kno2 for us, the patient experience is significantly better. What the patient has to do is they have to verify their identity. Fasten's able to then query the network and get a list of all the institutions that have previously treated this individual. So they don't need to remember every single institution that they've visited for treatment. And then in most cases, we can actually query the network and actually pull down their records without the patient having to do any sort of portal login, right? Remember a username and password for an institution that they may have visited once, may never have created a portal account for in the first place, right? It could be, I don't know about you, but I've visited numerous urgent care facilities, and I never created a portal account with them. And so there's all of these various friction points that exist in these patient access APIs and the portal mechanism for consent for accessing data that does not exist in the TEFCA side. And it is a much more streamlined experience for the patient, and it's going to get better with things like the CMS line networks and the health tech ecosystem as well.
So, Whitney, I want to just touch on a couple things that Jason said. Back to your question on, and I get asked it all the time, is, why is interoperability not been solved yet? And I always say, which part, right? So there's, interoperability is a big word. I won't go down that path right now. Besides the technical things and some of the regulation that we've seen, data silos have been historically very profitable for organizations. So there's absolutely been an economic reason that data has been, I mean, that was value for a while, for whether it's an electronic health record vendor, a health system, a provider. I don't want to demonize anybody, but to say that money wasn't being made off of access to data silos is, you'd be foolish to not believe it has. And I'm not saying it was inappropriate. It was allowed, right? And we're in a fee-for-service world where I don't care if you had an X-ray pulled at some and performed somewhere else. I'm going to do it again because I get paid to do it again. And I'm not going to go try to pull that record. So moving into value, the 21st Century Cures Act, as Jason touched on, absolutely is starting to flatten, I'll say, the landscape. Positive drivers. I hate it when regulation has to be the driver, but that's often necessary in these types of situations. But AI is also exposing, and then participation by big names, Apple getting involved, Google getting involved, and some of these groups that are interested, people start to pay attention, and it starts to switch the conversations to, oh man, we better figure out how to participate. And no longer is data the asset. I had to do a panel presentation a couple weeks ago on this about AI, and it used to be I could go into a meeting, and I'm truly not saying this in an arrogant way, and I probably held the most information in the meeting on interoperability, right? And so I was the information source. That is no longer the case. Like, I'm not going into a meeting. It's like everybody is one search away, one prompt away from being more informed than I am on any given topic. And so data is no longer king like it used to be. It now is, what are you doing with the data? So it's changing the minds, it's changing the industry so fast that we're having to play catch up. So the things like Jason's touching on, some of the technical challenges, like patient portal logins, patient matching, there's a lot of perceived or created or real barriers to working through some of these challenges. And the good thing is now they're being exposed at the highest level right now. Here's the challenge, let's work around it. I think there are some moves if some of these issues are real, and I'll just, again, not demonize anything or anyone here. If some of these issues are real, some of the moves that, like, for instance, I think it would come from the OCR, Office of Civil Rights, could make is protecting release of patient's information, because it's not covered under HIPAA. So if you do have a breach, for instance, a patient requests records and it ends up being somebody else's record that gets exposed, that providers and the systems associated are protected from that, just like they are under HIPAA. If I accidentally fax your record somewhere else, I'm protected. We could make some moves that way to provide that provision to some organizations if it starts to eliminate some of the fears around it. Would like to see that, because it just gets, whether it's real or not, let's just put it to bed and get some of those protections out there for patients to be able to get access to this information and be able to do it at scale.
So it sounds like the blocking access is it was a technological piece. Now that's not so much the issue anymore. And it was maybe like what you mentioned about there's a lot of revenue to be made in a data silo. Is there anything else that providers face that makes it difficult for them to get access to patients? Like, what's the obstacle for them?
Well, I think there's a lot to that question, because I think there are still technological barriers. There's still barriers that we need to continually work through, but nothing's insurmountable. Technology is the easy part. I always say that. Technology is the easy part. You put a bunch of bright minds in the same group, they'll figure it out. They'll figure out how to solve it. It's all the stuff that comes with it. The larger question on being able to get access, as we talked about, if Jason's serving 10% of the 700 to 900,000 provider organization, this is truly a technology challenge. So we're working, and we know this firsthand, and putting a massive amount of resource to it. And we need to spend more time educating people on how much time we're spending and how much time our EHR vendors are spending in these spaces to get their systems up to snuff, basically, to be able to handle. They've never done patient portals. They didn't have to. So maybe that's good. Maybe they don't have that perceived barrier. Consent. How are they handling consent? And the patients, there's very simple things that, when I always say Epic, Oracle, some of these other groups have had 22 decades to bring their interoperability practice forward and mature it. These organizations are literally brick on an accelerator trying to get from 0 to 100, but their technology, their policy, their regulation, how they're educating their end users, their sales and marketing, they're having to change everything. And this is a very real thing that we're working with these EHR vendors that serve thousands of providers each to make sure that they're capable of responding, auditing, logging. It's all of the stuff that Epic and Oracle have worked on for 2 decades and that they've had the benefit of, that these groups are now saying, wait, I got to do this. I got to think about this. I got a lot to consider. And we're right alongside of them. But there is truly technology that's going to take us just a bit to get all of those providers online and be able to do that.
So, Jason, I want to come back to you and talk about what happens when patients can't access their records. Therasa kind of touched on this idea towards the beginning, where patients become sort of like the middleware, the vehicle for carrying records around. I want your perspective on that. Like, what's the problem with that? What happens, and how does that impact health outcomes?
Yeah, well, I mean, I'm one of many examples of what happens when it's difficult to get access to your medical data. So I was diagnosed with a fairly serious medical issue that required me to onboard with about a half dozen healthcare institutions in the span of about a month and a half. I ended up getting duplicate blood work, duplicate imaging, because the left hand doesn't know what the right hand is doing. And so to make sure that all of my providers were on the same page, I became a paperwork mule, right? Shuffling medical records from one institution to the other, had a little file folder like a lot of people do. And that file folder just continued to grow and grow. And I saw myself turning into my parents, right? I was like, I was going to have a filing cabinet full of medical records at some point. And that's where I went, this isn't going to scale. This isn't going to work. I lived in a small condo in San Francisco. Like, there's no way that I had space for this. So I tried to look for apps that would help me manage my own care. I looked at and found Microsoft Health Vault, Google Health, these defunct attempts at building a personal health record app, a PHR. Unfortunately, because they weren't around any longer, and maybe just a lack of Google foo on my side, I wasn't able to find any modern alternatives. So I ended up putting on my engineering hat and saying, all right, well, are there APIs that I can connect to? And that's actually what started me down the journey of building Fasten. But kind of going back to like what happens when a patient can't access their own medical records, my story, right? My story is not unique. Many patients have to do this. They become a conduit for making sure that their providers are up to date on what's actually going on. And that's not how it should be, right? You're putting pressure on the patient. You're putting this additional responsibility on the patient at a time that's probably the worst, or one of the worst times in their lives, right? Where there's already a lot of anxiety, a lot of fear, a lot of concern about their own health. And now they have this additional responsibility to make sure that they're sharing all this information with their doctors, with an implication that if they miss or they don't share the correct information in a timely enough manner, it could impact their health that they might not fully understand either. That's terrible, right? That's a terrible experience to live as a patient. And so, yeah, it's really important that we find ways to unlock these pipes, to make them available to the patient, to the organizations that are helping support the patient. And it can be other physicians, sure, but it could also be caregivers, family members, support systems, right? There's all of these reasons why a patient might want to give their data to other individuals. But let's also not forget the fact that a patient themselves might want to understand what's actually going on, right? So I think we can all agree that medical records are generally not written for the individual. They're not written for the patient. They're written for billing systems. They're written for other physicians to understand and parse. But with access to the data, and with the ability for AIs, LLMs, and these other kind of tools and services that exist out there, we can help the patient understand what's actually going on in their own records. And I think that's what's really unique about this kind of time that we're in right now, where we're seeing that the floodgates kind of open. Data is now a lot more accessible. And with the advent of AI and LLMs, like you're able to find ways to translate this data that in the past has been kind of out of contextually, it wasn't really designed for the patient. Finding ways that you can translate that so that a patient can actually understand it and empower the patient to be more actively involved in their care rather than being a passive participant that's just sent from one institution to the other and told to just sit there and have things done to them, right? So I think there's a lot of power in kind of opening up this data and pushing this whole space forward, right? Where patients are more involved and actively engaged in their own care.
I've got a lot of opinion on this, Whitney.
Go
It's
ahead.
shocking, isn't it? I was going to make a joke. You know that show, is it Between Two Ferns? I always laugh when I watch it. Zach, I can't say his last name, Galificano, whatever it is. I had to look this up. So I have these two plants. If those that just are listening, I have two plants that are sitting on the left and right side of my head. I had to look at what kind of plant they are because I have no idea. They're called snake plants. So I'm like, how fitting is it that we're talking about we're demonizing parts of healthcare? Why isn't it there? I'm sitting between two snake plants. Here I am. I've got a lot of opinion on this one. As I mentioned earlier, it's like I completely relate and empathize with what Jason's saying. I have been, and my sister more so than me, have been through this with my dad, where he is 85. I don't know age him any more than he is. 85-year-old Parkinson's patient, osteoporosis, broken both his hips, has broken his right femur, has broken his back 6 times. Like everything that you could have, he has had and somehow has continued. But his primary care doc is a neurologist, right? So I've related this experience before, but it's so fitting to this conversation. He had, when he broke his left hip, I think, he had gone through, this was the initial break besides his back that he had had. So he was in rural Minnesota visiting my other sister, got a lot of sisters, visiting my other sister, and he was transported up to the cities. When he fell, they took him in at one of the major health systems in Minneapolis, St. Paul. Took him in, they got him in for surgery. Of course, he had to stay in for surgery, and then he had a stent at the rehab facility, was in there for multiple weeks while he recovered from that, and then released. And within like 3 or 4 weeks, he had his reoccurring appointment with his neurologist. So it occurred every 3 months. I happened to be home for that, so I took him to his neurologist appointment. And I got there, and I've expressed this before. So I'm wheeling my dad in. He's Parkinson's, so he has all of the symptoms of Parkinson's, right? Shaking and everything else, and neurological challenges. They hand me a 12-page, 14-page, like this huge packet. And normally they'll hand it to the patient because I saw him do it when I was there. And I'm sitting there, I'm like, is this a joke? Like, so I wheel my dad up. So I start looking through the questions, and it's basically, tell us what has happened since we've last seen you. If I summarize the intent of that packet, is tell us what's happened. In his case, 3 months ago, in the last 3 months. Well, some pretty significant things have happened in the last 3 months. And oh, by the way, this neurologist, and I'm not picking on the neurologist, is part of the health system. And so was the rehab facility, all part of the same health system in which he had the surgery, in which he had the rehab facility, and now he's seeing his neurologist. So the assumption I would have as a patient that my information is readily available, and my neurologist would have been fairly given the opportunity to readjust my plan of care before I got there and not do that real time. That's what happened. So I look at this document. I said, I'm not filling this out. So I went back up to the front and I said, I won't fill this out. You're part of the same health system. You have, and I know what EHR they have. You have access to my dad's record. This should have been done before. And I wasn't being mean. I was being very direct as I can be. Like, you have access to this. And I want to, when I go back to the neurologist, I'll walk her through how to use your EHR and how to find these records. And so in advance, so she knows she's sitting there real time doing this thing. So I sit in there, and I was thinking about Jason's point. All that said is the neurologist was shocked, didn't know they had access to it. And I was thinking about how would have my dad or my sister engaged? How would that have helped that situation? If the patient shows up with an app that they have their records on, they could have sent it to the provider, but she's still learning real time, right? She's still trying to readjust his care plan real time. And I go back to, let's not use individual access and patient access to solve care coordination problems. We have a systemic institutional problem that has to be fixed. And the good news is it is. In TEFCA, they go hand in hand. So if an EHR comes online for individual or for treatment, which they are, so they can get access to clinical records to solve the care coordination problems, they also have to solve IAS. That's a fundamental requirement. Both have to be done. in TEFCA, which is awesome. The question I always ask is, imagine, besides solving for, like, we're just like literally plugging the dam because we have so many problems, and now we've moved the responsibility to the patient because we can't seem to have solved it. Finally, I hope we're getting there. Imagine what we can do for the patients when we give them agency. When we give them agency, like Jason's touching on. So not just reactive, like, oh my gosh, I'm going to go see my primary care doc next week. Does he know I had this event, or he or she know I had this going on, and I'm going to send this? Where do I send it to? Do I walk in the front door at the time of the appointment? Doesn't do anybody any good. Like, the patient doesn't understand how the healthcare system works, nor should they, nor should their family understand that. But that's what we're doing to these patients, versus a caregiver, to Jason's point, in the case of my dad, or Jason as a very highly capable technology person and has agency to now participate in his care the way that he should participate as a patient. Understand all his conditions, be able to feed an LLM, speak to it in patient, speak to me as a consumer, not as a provider. So interpret those records. Let me look for my own wellness course. Let me look for my own kind of path in which I want to guide my own healthcare, and not have to be thinking about, oh, does that PT have access? Does that PCP have access? Assume they do. And now I can have a really great conversation because they're working from the same set of data that I am. And it is the real benefit, I'd say, of patient access and individual access when we get there as an ecosystem. I'm super excited for what it does and the opportunity it brings forward to truly set our patients free and truly start to see healthcare change. I just think there's huge opportunity. And sorry to be negative Nancy on this topic. And Jason, hopefully that doesn't offend you. But I want to make sure that we're staying focused to the true value of what patient access and individual access could do.
So you mentioned the future and imagine what's possible, Therasa. Let's talk about that. What is possible when the infrastructure works the way it should, when patients have access, when they're connected to their providers? Like, we've talked about how it's streamlined the process for patients. Patients aren't the middleware anymore. And is there anything else possible that wasn't before?
I'd actually, not to punt the question, Jason's going to be much more on the front lines. He gets to see all the different use cases that come to him for use. Love to get his answer on what he sees as the future of patient access and individual access. And then I'll opine on that.
Yeah, I mean, I think what it comes back to for us, right, what we're seeing a lot of is this creation of like personalized experiences for patients, right? Once you're able to access a full comprehensive copy of an individual's medical history, you can build individual personalized care plans. You can build experiences that help a patient more intelligently kind of understand their own care, what's actually happening to them, maybe even coordinate with a wider community of other individuals that are kind of suffering from the same type of condition. Right, rare disease registries are a thing that have been around for a very long time, but they've been very difficult to, I think, manage and scale because of how problematic and how difficult it was to actually access the raw data. And so, people would find each other in these forums, in these communities, and kind of discuss the conditions that they had, but they weren't really able to take that to a level where they could use their medical records as a whole, as a group, as a community, to try to better understand what works and what doesn't. And when you give everyone access to their medical data, you kind of unlock some of those opportunities, as some of those possibilities that were very difficult to do in any sort of meaningful way in the past. I would also say, I kind of touched on the legal aspect of, or the legal value in accessing medical records. There are a number of organizations that we're working with that are attempting to help patients with claims and billing and denials, essentially, right, to their treatments and et cetera that have occurred. And that's one of the really frustrating things as a patient, right? You go through this process, you're visiting your healthcare provider, you're getting advice on what to do next, how you can better your health, maybe prescriptions or some procedure that needs to be done, and then you wait 3 months and you get a bill in the mail, and that's when you find out that maybe that care that you'd already gotten was not qualified under your insurance plan. And so like there's this huge disconnect. And again, you're putting all this pressure, all of this responsibility on the individual to kind of figure it out on their own. And they feel like, you know, it's like a David and Goliath kind of story, right? They're just an individual. They're, you know, already there's all these other things that they have to take care of. But a big health system somewhere is basically saying, no, you know, what you thought was covered is actually not covered. You need to pay us this massive amount of money. And so I think there's a lot of the kinds of organizations that we're working with are trying to help patients take, you know, better understand their own care, help them kind of fight back against denials, helping them, you know, coordinate the sharing of records between the different individuals that maybe helping them on their journey, or it could just be, you know, helping communities better understand what how their different treatments are actually impacting their general, you know, condition as a group. There's so much different value here, but I think what's really interesting is just like, you know, the analogy I love is I always point back to plaid. There are going to be applications and organizations that are going to come out and build on top of this data that we're not even considering right now, right? Prior to Plaid opening the door to financial data, an organization like Venmo or Mint couldn't really have existed in the same way. And people weren't really thinking about them. It just wasn't possible to do that. With medical data, I feel like we're going to find whole new types of healthcare verticals that are essentially going to be created, that are going to be patient and consumer centric, that are going to let patients, you know, pull in their records. They're going to take that as the status quo, and then they're going to be pushing that forward and saying, all right, well, now that this data is ubiquitous, now that patients have a real, meaningful, quick way of getting access to their own data, what does that imply? What can you do with it? And I think there's going to be some very innovative, very interesting types of applications that I'm probably not creative enough to even think about right now that are going to come out of it. So yeah.
I'll use the example. I'm going to play off what Jason said when I speak to agency, giving patients and their caregivers agency. I'll speak to specifically, again, I'll use the example of my dad. What that would mean is he / my sister in this case, primary caregiver, myself, is knowing he has 5 specialists, what they all have said, and being able to reconcile it. Understanding why he's on, I think right now he's on 8 medications, understanding why, not just why they're on each of their 8 medications and what they're doing, what effectively those medications are doing, why certain procedures are ordered, why he's had certain, you know, symptoms showing up. Having my sister in this case and any member of our family being able to meaningfully participate in his care. Again, that's agency. And also giving him, in this case, again, my sister, the choice to say, you know what? And she has, because she is a very studious person. She has kept track of all his records. She's got like binders. She's got all of this. It's amazing what she does. Applaud her every day. But being able to say, you know what, this intervention isn't for him, or this treatment isn't for him, and here's why. And not putting, this is where I'll shift it and say, not putting all that burden on the provider, because they're seeing tens of patients every day, and you know they have to carry this load. While I'll put the care coordination load on them, being able to understand the individual needs of each patient, what their social determinants look like. There's a lot that goes into it. That's an unfair ask to put on our providers. So that is where a patient can engage and be their own advocate, or their caregiver be their own advocate, but agency. And I think Jason's point is spot on. I've been listening to a lot of podcasts on the outcomes of AI. Everybody's got lots of opinions here, and asking what it's going to be. And like, nobody knows, right? And those that try to predict the future probably are wrong. But with the case of individual access and patient access, I think this is a good example, is that the world is our oyster here, in terms of once we get this problem solved, in terms of where it can take us and what we can do with it. I do want to, keep punting questions to Jason. Sorry, Whitney, I don't mean to take over your role here. One of the super exciting things, and we're just in the early stages, Jason, I don't mean to speak for you here, is that Fasten is also looking at being a really good participant on the network. So We've talked about these apps getting access to records and being able to access that on behalf of the patient. But a lot of these apps are also collecting patient-generated data every day. That I think there's like 8,760 hours. I've got that wrong. Some huge number of hours that patients have all of these events going on in their body all day long. Most of them probably, sorry to say, meaningless to the provider world, but some very important to a patient, all very meaningful, right? That they're collected, all very meaningful, but talked about a provider world. So Jason, I'd love to have you just kind of, to the extent you're comfortable and able, talk about patient-generated data coming back in from Fasten. They'll be one of the first, if not the first, IIS application to, I'd say, be a good participant, a custodian of the network, and a good participant on the network.
Yeah. So let me maybe just pivot slightly first before I answer that question. I'd like to say that there is, in a lot of cases, you're going to find that the patient is actually the source of truth for some of the data that's actually found in the medical record. So, a patient goes to a healthcare provider and there's an intake form that they're filling out, and the physician's asking, or the institution's asking, what medications you're currently on, why are you here in the first place? What are you actually visiting this institution for? What kind of problems do you have? Give me more information about your medical history, your family's medical history. All of that is kind of coming from the patient as their source of truth. It gets entered into the EHR and then maybe gets disseminated via the networks to other providers that the patient visits in the future. But the source of that data was the patient, and they're the ones that know exactly what's actually going on with medications that they're actively taking or not. And so what we've found is that there are a lot of patients that are using some of these applications. They're actually for the first time being able to aggregate all of their different health records from all these different providers that they visited over potentially decades. And they're seeing incorrect data all over the place. They're seeing medications that are still active that they have not been taking for years. They're seeing maybe procedures or misspellings in their record, things that just did not happen or that are incorrect. They're seeing, family medical history that was maybe inaccurately entered into the system, or maybe like even sometimes diagnoses, et cetera, that are like incorrect. A patient might have said that they smoked, but it was entered in as that there was like they're an active smoker all the time, right? And so there's like all of these pieces of information that are incorrect that a patient then asks. The next question they have is, how do I fix this? And that's very, very difficult to do as a patient, right? You in theory could go to every single institution and say, all right, well, here's what I know is incorrect that you in the record that you have for me. Please fix that. But is that information then going to be disseminated out to other physicians and those changes going to be made on those other networks? Not necessarily. So one of the things that's kind of interesting about the power of these networks is when Fasten helps a patient aggregate all of their records inside of an app, the patient has the ability to say, oh, let me correct these things. You misspelled my last name, or I'm married now, and here's the correct last name that you should be using. You have 5 medications that I'm actively on, but I'm only actually taking 2 of these. They can correct some of these differences between what the physician and the health system thinks they're actively, doing versus what the patient knows they're actively doing, and share that data back to the network so that the next time they visit a healthcare provider, the provider who's pulling data from other institutions on that same network can also pull data from the patient's PHR app, right? Where the patient's contributing back information that has been corrected, that is accurate from the viewpoint of the patient. So that's a world that we want to live in. That's what we're trying to focus on, right? Not only pulling the data from the network, but helping a patient contribute changes back to the network. There's also, a variety of different types of records that patients have access to that maybe aren't commonly found on the health systems, on the health networks, things like genomics information, right? A lot of things that are done kind of, let's say, out of pocket where a patient's, paying for it on their own, but might be completely relevant for the kind of treatment that physicians want to prescribe to a patient. So there's all these kind of use cases, and we can talk about, you mentioned, there's trade-offs with this kind of data. If you're talking about, wearable information, just the volume of information that could be shared back on the network, I think there's definitely going to be trade-offs in the future that we're all going to have to consider. But at the same time, it should be up to the patient if they want to share this data or not. Yeah.
I totally agree with that. And Jason, I want to, maybe I'll come off my aggressive stance on saying care coordination isn't a responsibility of the patient. I still feel that, but you're absolutely right. Is there, instead of them worrying about, did my provider get my records from the community, is now it frees up the time to have the conversation. So instead of Jason sitting in there and saying, hey, have you seen any of my records? Let me get them to you. And so then the provider's trying to read through them real time. Let's not do that. But to exactly your point, is let the patient participate in being their historian in some cases, where they can say, that's right, that's wrong. Because we have a mountain of data that is inaccurate, aged, that we need to get through and affect and change. And what's interesting about what Jason said, I was thinking about the reverberation off of it is, so let's say Jason goes to his PCP, has to correct a bunch of information, I shouldn't say, he has to correct some information. Now that PCP has made the updates, and it will be the most current record for Jason on the networks, right? So now because if by date timestamp, it'll be the most current record on the network in the community in which Jason lives. And so the next people to pull the record, let's say somebody does a zip code search, another provider does a zip code search that Jason's going to see. By age, they will see that the most recent record is the PCP. And so things like medications that have been updated and reconciled, problem list, is the historical information that Jason's worked with, we have now reset going down the path, right? So unless the system that's pulling that record is also absorbing all the bad data, which they shouldn't do, good practice is, hey, the most recent PAMU list, the most recent set of data should be my source of truth. So when he goes to see the specialist that now pulled the record from the PCP, along with the other ones, but they're looking at the PC records as the primary source of truth, now I'm having the real conversation. It's like, oh, yep, that's right, you got it. What a great feeling when we have a coordinated healthcare system that works that way, that says, hey, the patient is engaging, I'm pulling good data now, I've reset the button on the data, and here we go, right? I was just thinking about, as you were explaining it, I mean, like the downstream impact of what you were describing, Jason, is huge for the provider community also, because now they're not pulling junk data and having to reconcile it with Jason, or if they do, they can get through it quickly because it's now right. I never actually thought about that. So that is now a new talking point for me. That's a really good discussion.
All right, so we are about out of time for today. I want to ask you both one last question. If you are a healthcare organization, you can talk about payers, providers, whoever you want to talk about, whoever you want to focus on. But what do they do next? Like, this is a big topic. We've discussed we've talked about obstacles. We've talked about how exciting the future could be. What's the next step? What's the next thing they should do? Jason, we'll come to you first, and then Therasa.
From our perspective, it's just connect to a network. These networks are only valuable when they're ubiquitous, when everyone is on them, when you're able to get that comprehensive longitudinal history, right? If we continue to see fractured, like multiple networks or fractured networks, isolated health systems, you're missing the patient's missing the benefits, right? They're unable to build that comprehensive history in their app of their choosing. They're unable to easily access the data and aggregate it all on their side. And so the thing that I would strongly advise is just connect to a network, make it easy for the patient to access their records, make it easy for other physicians to have the accurate, most up-to-date information about the patient. And that is, I think, overall, that the networks are so much more valuable for everyone involved when there's more participation.
I don't have any. I mean, that's exactly right. Let's not let progress get in the way of perfection get in the way of progress. Is that right? Maybe I should. We have to make progress, right? And getting connected, albeit in an imperfect state, It's okay. And some of the imperfect states we don't know until you're connected, and we can work through them quickly. But get connected. Totally agree with Jason. Let's make progress on the base. Let's make progress on, I've said that for a long time, is until I have all my providers, back to this provider-centric mentality that we have, connected, I do Jason no good, right? So it's like, I have got to have our EHR vendors, our providers stay the course, get connected. We're going to sand the rough edges here as we continue to learn things and do things better. But until we have data moving, we can't make things better. We're waiting. So concur. Couldn't agree more.
Connect. That's the
Connect.
final answer. Connect. Well, thank you, Jason, for being here today. Where can we find you online for people who want to follow you, see what you're up to?
Yeah, so you can find us at fastenhealth.com, or we're very active on LinkedIn as well under Fasten Health.
Awesome. Thank you. For those of you listening, watching, if this conversation resonated with you, check out fastenhealth.com. I want to get it right. And check out Kno2.com to see what we're all up to. Thanks, everyone. Have a good afternoon.
And share the podcast.
Pleasure.
Share the podcast.
Share the podcast.
Yeah. Get everybody to listen.
Yeah.
And that's a wrap on Kno2fy. To learn more about Kno2, or if this episode sparked something, visit Kno2.com. We'll see you next time.